Good evening, everyone. Welcome to the FCPI year-end review papers. Today topic is top 10 PKPD and PKPD and TDM papers. And my name is Dr. Saidulu. I'm your moderator today. Our speaker is esteemed expert in the PKPD and TDM, Dr. Veena Venugopalan. Dr. Veena Venugopalan received her Doctor of Pharmacy degree from University of Kentucky College of Pharmacy in 2016. Thereafter, she completed pharmacy practice residency in infectious disease specialty residency at University of Kentucky Medical Center. And later, she joined as a faculty in University of Florida in 2016. She currently is a clinical associate professor at the University of Florida College of Pharmacy and serves as one of the infectious disease clinical specialists at the University of Florida Health Science Hospital. As a board certified pharmacist in infectious diseases, she has dedicated much of her career to developing and maintaining the antimicrobial stewardship programs at large academic centers as well as community teaching hospitals. Dr. Veena Venugopalan has received local and statewide recognition for her innovative antimicrobial stewardship activities. In addition to Dr. Veena Gopalan research and clinical interest in antimicrobial resistant beta-lactam TDM and antimicrobial stewardship, she is also passionate about the global health. Dr. Veena Gopalan is a teacher and mentor and advisor to the pharmacy students and residents. And thank you, madam, for accepting our invitation. Stage yours.
Thank you so much for that kind invitation, and thank you for the organizers for giving me the opportunity to present here today. So today I'll be presenting some key PKPD and TDM papers from 2023, and these are going to be presented in no particular order. So the first study here is by Bock and colleagues. The paper was published in Clinical Infectious Diseases and is titled Attainment of Target Antibiotic Levels by Oral Treatment of Left-Sided Infective Endocarditis, a POET substudy. So as you all know, infective endocarditis of the left side of the heart is typically treated with long courses of antibiotics, specifically intravenous antibiotics. And so in 2019, the POET study, which is at this point a landmark study, which is partial oral versus intravenous antibiotic treatment for endocarditis, was conducted. And the trial specifically looked at switching from intravenous to oral therapy. And there were a couple of key findings from this study. The first was that oral therapy was non-inferior to conventional intravenous therapy after 6 months. Number of relapses of positive blood cultures were similar in both the intravenous and PO groups. And oral antibiotics, oral treated patients rather, had significantly reduced mortality rate after a median follow-up of 3.5 years and also after 5.4 years. So key question that we've all had, and I think a question that this study, which was a sub-study of that bigger POET trial, was, did changing from IV to PO, from intravenous to oral therapy, impact antibiotic PKPD in the POET trial? Because this study was really treating these high inoculum infections, these complex, deep-seated infections. These patients all had infective endocarditis. So in this sub-study, in the POET sub-study, plasma levels were obtained at day 1, so that's day of randomization, and then after administration of a single PO dose. So they obtained levels for these antibiotics at 30 minutes, and then at 1, 2, 4, and 6 hours after administration, and then subsequently again on day 5 after administration of several PO doses. So we assume that that's steady state concentration. Samples were also obtained from patients who are on the intravenous treatment on day 1. So the inclusion and exclusion criteria are those of the POET study. So these included adult patients who were in stable condition. They were receiving intravenous antibiotic therapy for left-sided endocarditis, either on their native or prosthetic valves. They fulfilled Duke's criteria. They had a blood culture with an organism that was consistent with infective endocarditis. They had received at least 10 days of intravenous therapy, and it had been at least 7 days following heart surgery. Exclusion criteria included any evidence of an abscess or valve abnormalities, BMI greater than 40, concomitant infection requiring IV therapy, patients that had any absorption concerns, those that did not have available PK data, any patients that had a single antibiotic concentration, those that had irregular concentration or outlier concentrations, and this was further defined in the study. For example, an irregular concentration, regular concentrations were defined as concentrations that increase and decrease as a general pattern, or if they constantly increased and or if they constantly decreased. So anything that wasn't in that regular expected trend was considered irregular. Okay, so the antibiotics that they looked at are presented for you in the yellow bubble. So amoxicillin, linezolid, moxifloxacin, rifampin, and dicloxacillin. So the POET PK sub-study included 236 patients. 175 received 2 oral antibiotics, 35 received 1 oral and an adjunctive IV therapy, and then 26 received IV antibiotics only. So of these patients, 251 and 189 patients at day 1 and day 5, 251 and 189 treatments at day 1 and day 5 of 179 patients were included in the PK analysis as well as the MIC analysis. So these patients, 179 patients, also had MIC that were available for analysis. So the reason that the 251 and the 189 are referred to as treatments, the study defined a treatment as a PK data series for 1 antibiotic on 1 assessment day. Okay, so that's the difference between a treatment that's defined for the study and then the individual patients. So as I mentioned, 179 patients had MICs that were available. So they had an organism with an MIC for the MIC analysis. Then you had 355 and 248 treatments at day 1 and day 5 from 236 patients that had available PK, and they didn't have MICs, but we used the breakpoints for analysis. So the primary outcome of the study was looking at probability of target attainment. So these are the percentage of patients that were reaching the target in relation to MICs. And whether that was the MIC, the pathogen they had, or the breakpoint, it depended. All right, so let's first take a look at the concentration time curves for the antibiotics that were reviewed in the study. As you can see, for amoxicillin, for moxifloxacin, as well as for rifampicin, the concentrations that were obtained on day 1 and day 5 pretty much mirror one another. The same cannot be said for linezolid and dicloxacillin, where you see that concentrations on day 5 were significantly greater than those concentrations on day 1. Next, let's look at the percent of free time above MIC versus the percent of free time greater than the breakpoint. So those are the two panels that are side by side, and the first one that we see is for amoxicillin. So the first panel, once again, is for those patients that had available MIC, so we had pathogens, and the second panel represents a target attainment using the breakpoint. So as you can see, overall, probability of target attainment, which is represented, the target is represented as the horizontal line. So the goal was at least 50% target attainment. You achieve that pretty comfortably when using the MIC of the pathogen, probably because the MICs were much lower, versus you see the probability of target attainment is lower when using the breakpoints for amoxicillin. For dicloxacillin, you'll see that probability of target attainment was much lower, possibly because of the high protein binding for dicloxacillin. So for linezolid, you see that here the AUC to MIC was the goal PK/PD target. And as you can see, overall, you have much lower probability of target attainment with enterococci and staphylococci using the breakpoint. There was only between 27 to 54%. And for streptococci, using the breakpoint, probability of target attainment was only between 67 and 84%. But using MICs overall, for both enterococci, staphylococci, and streptococci, you had good target attainment both at day 1 and day 5. Similar findings you see with rifampicin as well. Overall, you see that probability of target attainment, so the AUC to MIC, so AUC to breakpoint goals were attained between 81 to 65% when compared to the breakpoint. And you see better AUC to MIC goals that are attained when compared to the MIC for both staphylococci and streptococci. Similar findings are seen with moxifloxacin as well, where you see lower attainment of these targets when you're comparing it to the breakpoints. Now, I draw your attention to the data that's presented in the table. So there were some patients that received 2 oral antibiotics. So about 74 patients at day 1 and 65 patients at day 5 had available PK and MIC for both antibiotics. So what you can see in terms of PK/PD target attainment is that on day 1, about 82% of patients had attained PK/PD targets for both the antibiotics, both the oral antibiotics they were on. And at day 1, about 18% of patients, 13 patients, had attained PK/PD targets for one antibiotic. And at day 5, about 77% of patients had attained PK/PD targets for 77% of patients versus about 22% that attained it for at least one antibiotic. So the summary of this data suggests that majority of patients do attain PK/PD targets using oral step-down therapy. So I think that this the data nicely represents that oral antibiotics that have a reasonable bioavailability are good options as treatment for these deep-seated infections such as infective endocarditis. So in the POET study, in this subset of patients with available PK data, you do appear to get those or achieve those PK/PD targets. Also, I think it's reasonable to use combination therapy because as we saw when you're using 2 oral antibiotics, you had high PK/PD target attainment for both those oral antibiotics. But even in the cases that you may not, you may get some additional increased likelihood of target attainment, even if you don't hit that target with just one single agent. Some limitations of the study are the small sample size. They had excluded a large number of patients for a variety of reasons, such as missing PK concentrations due to MIC issues, etc. And remember that the sub-study was not really powered for a subgroup analysis. So this was the PK study was done as a safety endpoint of the larger POET trial. External validity is always a concern because they excluded patients that had BMIs greater than 40. And also remember these patients were transitioned from intravenous therapy. And so that may have diminished some of the differences that we could have potentially seen between target attainment at day 1 and day 5, since these patients were previously on intravenous therapy. So it brings us to the second study, and this study was done by Ewald and colleagues. The study is called Model-Informed Precision Dosing of Beta-lactam Antibiotics and ciprofloxacin in Critically Ill Patients. It's a multi-center randomized clinical trial. So some background about the study. So in critically ill patients, we know that these patients are highly susceptible to PK alterations because of the several reasons, because of the fact that they have altered renal clearance as their critical status continues. They may have variability in protein binding. They're certainly getting massive amounts of fluid resuscitation due to their critical illness. So all those things are contributing to their PK alterations. We also know that critical status and being in an ICU also increases their risk of developing infections due to resistant pathogens. Prior studies have concluded that empiric approaches, empiric dosing approaches to beta-lactams and quinolones in critically ill patients have resulted in poor target attainment. And there is emerging data that suggests that therapeutic drug monitoring is likely to improve PKPD target attainment, thereby improving clinical outcomes and decreasing antimicrobial resistance in ICU patients. So this specific study, the question that it was attempting to answer, the acknowledged gap it was trying to fill was, does early therapeutic drug monitoring using pharmacometric modeling of beta-lactam antibiotics and ciprofloxacin improve outcomes in critically ill patients? So the study's inclusion criteria included adult patients who were admitted to an ICU on one of the target drugs that they were looking at. So it included amoxicillin with or without clavulanic acid, cefotaxime, ceftazidime, ceftriaxone, cefuroxime, ciprofloxacin, meropenem, flucloxacillin, and piperacillin tazobactam. They excluded pregnant patients, antibiotic cessation before their first blood collection, if these patients were enrolled in another trial, if they were burn patients or receiving antibiotics for any other gut contamination indications, and if their hospital admission was related to COVID-19. So this was a multi-center open label study that was performed in ICUs. Patients were randomized in a one-to-one fashion to either a TDM arm or model-informed precision dosing or standard dosing. So let's take a look at the figure below that shows the study and sampling days. So T0 represents the first antibiotic dose. So that's the first day. And sampling was then done every 48 hours. So T1 is the first antibiotic sampling with dose adjustment. So it took roughly at maximum about 36 hours from T0 to enroll the patients in the study. So that the enrollment phase in itself took about, at worst scenarios, 36 hours. So T1 was the first antibiotic sampling with dosing adjustment. And from the sampling time, it took about 12 hours for dosing recommendations to be made based on that sampling. Then from T1, sampling was redone 48 hours later at T3 with dosage adjustment. Again at T5, 48 hours later. And then if patients were continued on antibiotics, then sampling was done at T7, but there were no dosage adjustments made based on this. It was simply done in order to determine whether or not the dose adjustments that were made at T5 actually resulted in target attainment. Okay, so this schematic just shows you how patients were randomized into the two arms. So just to walk you through this. So these are ICU patients. Once they were enrolled into the study and sampling had began, we obtained peak and trough, the study investigators obtained a peak and trough sample. These samples were then analyzed, and remember, these patients were randomized into two arms. The first was the model-informed precision dosing. So they used Bayesian forecasting and provided recommendations based on the output from the MIPD. And the recommendations were made to the medical provider, and then subsequent dosing adjustments were made. Now, the non-TDM arm also had concentrations that were obtained on patients. However, the providers were blinded to the results. So they got concentrations at exactly the same time points at peaks and troughs. However, there were no recommendations. So the results were blinded to the providers. So the providers were making dose adjustments based on local guidelines. The primary outcome of the study was ICU length of stay. Secondary outcomes were 28-day mortality, hospital mortality, 6-month mortality. They looked at change in SOFA score, change in CRP, white count, any adverse effects, and then they looked at pharmacodynamic target attainment. And they also looked at some quality of life measures as well. So there were 189 patients that were randomized to the TDM arm and 199 that were randomized to the standard dosing or non-TDM arm. So I want to just focus on a couple of demographics data points. So I've provided some dots just to draw your attention to those. So the antibiotic duration in both arms, if you look at the TDM versus non-TDM arm, it was about 4.1 days in the TDM arm versus 3.5 days. But if you look at the interquartile range, some patients were de-escalated pretty quickly off of these antibiotics. And so, we have to kind of take that with a grain of salt. So not all these patients had concentrations at all three sampling time points, T1, 3, and 5. ICU length of stays did not differ between the groups, neither did SOFA scores. So that was pretty much the same. Most patients had a pulmonary source of infection or suspected pulmonary source of infection. In terms of having resistant pathogens, about 16% in the MIPD or the TDM arm and about 14% of the non-TDM arm had intrinsically resistant organisms, but those percentages were similar. And in terms of baseline renal function, once again, the eGFR between the two groups was also very similar. So similar cohorts. Okay, so I just want to represent at least one of the findings, and that's shown for you here. The median time to first sampling was about 19.6 hours in the TDM arm and about 18.5 hours in the standard group. So I just want to point out that the time to sampling was also similar between the two groups. Okay, so let's go into some of the results. So the probability of target attainment for beta-lactams was free time greater than MIC for 100% of the dosing interval. And for ciprofloxacin, it was an AUC, 24-hour AUC to MIC above 125. So the study investigators did provide the study sites with recommendations on what to do with these concentrations. So there's some general guidelines for that. And they also did provide them with max dosing. So they couldn't escalate doses without any ceiling. They did provide them with maximum daily doses. So this is the results in terms of probability of target attainment. So the circular structure here represents probability of target attainment. The outermost ring is for T1, the next ring is T3, and the innermost ring is for T5. So we're looking at the combination of the light green and the pink portion. And what you'll see is that at T1, that's the first sampling opportunity, 40% of patients did not achieve probability of target attainment, right? So they either needed a dose increase or reduction, most commonly a dose increase. At T3, that dropped to 23%, and at T5 to 15%. So it sounds like from this data that the greatest opportunity for us to make these interventions in terms of dose optimizations occur earlier in these beta-lactam courses. Now coming to the primary and the secondary outcomes. Unfortunately, the study did not find any differences in the primary and secondary outcomes. In terms of ICU length of stay, no differences. In fact, there was a 2-day increased ICU length of stay in the TDM arm compared to standard therapy, even though this was not statistically significant. In terms of ICU-free days, no difference. Mortality, both ICU and hospital mortality. And they looked at several other things, SOFA score, CRP, white blood cell count, and quality of life indicators. None of those secondary outcomes really, there wasn't any differences between the TDM and the non-TDM group. So does this say that TDM is of no value for us because we did not find a difference in any of the outcomes in the study? Well, I think that I'm not sure that I'm ready to throw the towel in the ring as far as TDM is concerned, because I do think there's still some major limitations of the study. Still, I think the study does show a very clear signal that benefits with TDM in terms of dose optimization occur the closer you can get to time zero, right? Which is when we first start antibiotics, that golden hour. And this is a good indication, even with the best of these trials, the most well-designed, there was still a good amount of delay to get informed consent for these patients, which likely delayed getting our antibiotic sampling done. Also, here the study investigators did max out daily doses. So they did not allow the study sites to escalate doses beyond what they had recommended. So dose escalation certainly need not be capped for beta-lactam. I think there's still room to go up. Plus, they didn't really allow these patients to be switched to continuous infusions, which may have been another mechanism by which to optimize PKPD target. Definitely, this wasn't a blinded study, so I think the non-blinding could have biased outcomes. And I think there is a challenge with TDM studies due to what we refer to as this dilution effect. So the majority of patients did not require dose adjustments. So ideally, if we're going to conduct these TDM studies, we should be randomizing those patients that required some kind of TDM adjustment in order to study the true outcome of doing TDM guided dose optimization, because the non-adjusted patients do tend to dilute out any effects if there are any. And then finally, I think this goes to show you once again, that we still haven't quite identified the optimal outcome in these trials. And I think this is still evolving. I think that there are still some TDM studies in the horizon that we expect to come out that will hopefully shed some more light on what the optimal outcome is, because I think mortality is certainly not it. Especially in such a heterogeneous patient population. And some of these other clinical endpoints, such as SOFA and CRP and white count, really haven't panned out to be terribly useful either. Okay, so let's move on to the third study. And this was done by Pai and colleagues. And the study is titled Linezolid Population Pharmacokinetics to Improve Dosing in Cardiosurgical Patients, Factoring a New Drug-Drug Interaction Pathway. So some background is linezolid is currently utilized for a wide array of deep-seated infection. The duration of therapy is limited to 14 days and often not more than 28 days because of our major concern with thrombocytopenia with linezolid. Newer data really has linked abnormal kidney function to drug accumulation and development of adverse effects, particularly thrombocytopenia. And also this CYP2J2 has now been identified as a major contributing isoenzyme for linezolid metabolism. So current product labeling for linezolid does not recommend any dosing adjustment for renal insufficiency, body-side or drug-drug interactions. However, there are now some TDM consensus documents, guidelines that recommend that linezolid trough concentrations between 2 and 8 should be maintained to minimize risk of thrombocytopenia. So this particular study really addressed the question whether drug-drug interactions can impact linezolid pharmacokinetics, particularly in cardiosurgical patients, because they do receive some of these drugs that could potentially interact with linezolid. The inclusion criteria for study were adults, so this included patients greater than 18 years, those patients that received cardiac surgery and were receiving linezolid at standard doses, so 600 milligrams either intravenously or orally every 12 hours. Okay, so just the general schematic in terms of the methods for the study. So cardiac patients, who were receiving linezolid. The study investigators obtained peak and trough samples from these patients, and these were analyzed. Linezolid target concentrations were maintained between 2 and 8 micrograms per liter. Subsequent to getting TDM, the providers were provided advice on any dosage adjustments, and those were subsequently made to linezolid dosing. So the study outcome here was to identify any covariates and to test potential drug-drug interactions that may account for interpatient variability with linezolid in this specific patient population. So here are some basic patient demographics. So overall, this was a non-obese cohort of patients. They had diminished renal function. The EGFR was, the median EGFR was 46.8. The major use for linezolid in this cohort was for pneumonia. And in terms of duration of treatment, the median duration was about 12 days. Platelet count really did not vary from start of therapy to the end. And as you can see, at least half of this cohort were receiving concomitant medications such as amiodarone and cyclosporin that are known to have these interactions with linezolid. Okay, so let's first look at the linezolid trough concentrations in this cohort. And as you can see, so remember, these patients all was receiving standard doses of linezolid, 600 milligrams twice daily. 45% of this cohort had trough concentrations greater than 8. And these concentrations have been highly linked at this point in available literature to higher risk of thrombocytopenia. And the plot graph on the right-hand side shows you what the distribution of troughs. So this is on the left side, you see the median trough, which is represented by the horizontal blue line. That was with initial TDM. And then once dose adjustments were made, subsequent to TDM, that median trough concentration did drop. Okay. So when relevant covariates in the nasal PK models were analyzed, kidney function and the number of interacting drugs had the greatest influence on the nasal clearance. Specifically, cyclosporin was identified to have the largest effect in this reduction in linezolid clearance. So I want to draw your attention to 2 data points that were presented in the study. So the first set of bar graphs have probability of target attainment on the y-axis. On the x-axis, you have the number of interacting drugs. And it gives you the trough concentrations for various dosing regimens. And then you have each set of panels gives you different GFRs. Okay, so I want to draw your attention to the very last set of bar graphs, which represents our standard linezolid dose, which is 600 milligrams POQ12. Now, what you can see is that as the EGFR reduces, so let's look at the bar graph on the far left-hand side, that's EGFR less than 30. You see that when your EGFR is low and the number of interacting medications increases, you have a greater potential for having supertherapeutic levels. So those are levels greater than 8 micrograms per ml. So I think this is a nice representation how we should be really considering dose adjusting linezolid in reduced renal function, as well as if patients are on numerous or multiple concomitant interacting medications. Next, I draw your attention to the line graph, which represents the expected or the percent concentrations within the therapeutic range, while on cyclosporin at different estimated glomerular filtration rates. And as you can see, the different line graphs represent different dosing regimens. And for our standard linezolid dosing, which is 600 milligrams Q12, as your eGFR decreases, you have decrease likelihood of having a linezolid concentration within the therapeutic range. Once again, really showing that the impact that cyclosporin has on this drug interaction. So in summary, standard linezolid dosing leads to higher probabilities of exposures, at least in this patient cohort. And as you can see, TDM informed dosing can really improve linezolid trough attainment in cardiosurgical patients. So there is an additive effect of potential drug-drug interaction and eGFR, which may contribute to having higher linezolid exposure in this population. And based on this study, this drug-drug interaction relationship was strongest with cyclosporin, which resulted in the greatest reduction in linezolid clearance. Some of the limitations of the study is they did not correlate this exposure with any clinical outcomes, unfortunately. And also we do know that there's lower expression of CYP2J2 in patients that have cardiomyopathy and cardiac disease conditions. So we may not be seeing the full effects of this isoenzyme interaction because of the specific patient population. So let's move on to our next study. And this was performed by Monty and colleagues. It was published in JAMA. And this is continuous versus intermittent meropenem administration in critically ill patients with sepsis, the MERCY trial. And this got a lot of press and stirred a lot of feathers. So let's talk about this briefly. So some basic background first. Beta-lactams, as you all know, are time-dependent antibiotics. Right now, PK studies suggest that prolonging the administration of beta-lactams can maximize the time above MIC and improve the efficacy of beta-lactams. Systematic reviews and meta-analyses show that continuous or extended administration may reduce mortality in patients with sepsis. So this specific study, the question it was trying to answer was, does continuous administration of meropenem, giving meropenem as a continuous infusion, improve patient outcomes, decrease mortality compared to intermittent infusion? So the study included adult patients who were admitted to the ICU, who were receiving meropenem, who had sepsis or septic shock. They excluded patients who did not consent for the study, who were previously on carbapenems, who had low probability of survival based on their SAPS-2 score, and who had severe immunosuppression. So this was a multi-center, double-blind, randomized controlled trial that was performed in ICUs. Patients all had cultures that were obtained before randomization, and all patients received a loading dose of meropenem prior to being randomized to either a continuous infusion arm that got 3 grams of meropenem over 24 hours. And this arm also got a double dummy of the intermittent infusion with normal saline. And then the intermittent infusion arm got meropenem 1 gram every 8 hours with a normal saline as the double dummy. And these patients underwent a 28-day assessment. So the primary study outcome was all-cause mortality. So there was a composite primary outcome of all-cause mortality and emergence of pan-drug resistant or extensively drug-resistant bacteria at day 28. They looked at a couple of different secondary outcomes. They looked at days alive and free from antibiotics at day 28, days alive and free from the ICU at day 28, and then all-cause mortality at 90 days. So in terms of baseline characteristics, they looked like they were pretty similar group, the continuous and the intermittent infusion arm. Although there seems to be slightly more patients that had chronic kidney disease in the continuous infusion arm, but overall, a good cohort of these patients, about 70%, 65 to 70% of these patients had previous exposure to antibiotics 3 months prior. to randomization, and I'll tell you the significance of this. But in terms of overall just severity of illness, their SOFA scores, they were similar between the two groups. Okay, so in terms of all-cause, their study outcomes, in terms of the composite endpoint, the primary endpoint, which is all-cause mortality and emergence of resistance, they do not find a difference between the two groups, between continuous and intermittent infusion. In terms of secondary outcomes, they also did not find any difference between the continuous and intermittent infusion group. So when this study came out, there was a lot of discussion about how use of continuous infusion is obsolete. We don't need it anymore. There's very little value. And there's a lot of discussion. But I think the devil is in the details, because when you look at the study cohort, there are some things that come up that we really have to consider when evaluating the study outcomes. The first thing is, really weren't any difference in terms of the dosing of meropenem or the duration of treatment. But where you do start to see a difference is in one is concurrent therapy. Good cohort of this population was receiving concurrent antibiotics. Most common concurrent antibiotics were, no surprise, is a glycopeptide, was vancomycin. But about 20% of patients were receiving third and fourth generation cephalosporins. So it's surprising that they were receiving cephalosporin in addition to meropenem. That's an interesting finding. And then when we look at isolates that were not susceptible to carbapenem at baseline, 35%, so 35% of the continuous infusion arm and 30% of isolates in intermittent infusion arm were not even susceptible to a carbapenem. When we look at the different pathogens for Klebsiella, if you look at specifically, 50% of the Klebsiella isolates were resistant to the carbapenem, and 37% in the intermittent infusion group was resistant to the carbapenem, which makes you think if they didn't really discuss this, but if they had a KPC issue in the study, and whether that dramatically skewed their results. So their study conclusion is that continuous infusion does not improve outcomes in patients with sepsis, does not improve mortality either. But as I mentioned, the limitations, a big limitation is we don't know exposures, right? They didn't do TDM, so we really don't know what kind of exposure these patients had. They had a high prevalence of carbapenem-resistant isolates, and then nobody's really crazy about these composite endpoints, especially since they did look at all-cause mortality and not infection related mortality or mortality that's specific to infection. And also, as I previously mentioned, a large cohort of this population was also receiving concurrent therapy and concurrent therapy with other beta-lactams, with third and fourth generation cephalosporins. All right, so a couple of special mentions, and this is one of them. So this past year, we had the international consensus recommendations for the use of prolonged infusion beta-lactams. I'm not going to go through the entire document, but I just wanted to point out a couple of things. I think this is an important document for you to review if you are considering using some of these different dosing strategies in your institutions. So some of the graded or the expert opinions, expert recommendations that are provided for you in this guidance document, I'm just giving you a few of this. This is not comprehensive by any means, but I want to point out a couple of things. So they first answer the question about what the role is for therapeutic drug monitoring in prolonged infusion beta-lactams. And right now, the recommendation from the consensus document is that they cannot recommend for or against routine TDM in prolonged infusions at this time. When it comes to beta-lactam exposures, what is ideal? I think this is still a question that we all have. Right now, the consensus is that there is still insufficient evidence to recommend a single concentration or exposure for beta-lactams. I think this has been one of the frustrating things for us, but I think that we are getting closer to getting answers as to what may be optimal in terms of targets. But this consensus document provides some guidance, but does recognize that a single target is not recommended. And then they ask the question of whether prolonged infusion beta-lactams should be preferred over standard infusions in critically ill patients. And I think the consensus here was clear that prolonged infusion beta-lactams really should be preferred over standard infusions to reduce mortality and increase clinical cure, particularly in your critically ill patients and those that have gram-negative infections. However, when it comes to prolonged infusions in non-severely ill patients, I mean, similar recommendations cannot be made because of lack of evidence of similar benefits in non-severely ill patients. Whether we should be using loading doses over non-loading doses with prolonged infusion, the recommendations are you should be using a loading dose whenever you're initiating continuous infusions of beta-lactams. However, there was less of a consensus or recommendation with extended infusion strategies. And then finally, they answer the question of whether prolonged infusion antibiotics are safer in adults and pediatrics. From a safety standpoint, there could be no recommendation that's made over the use of prolonged infusion versus standard infusions in either adult or pediatric patients. So that safety data is not available at this time. Okay, so the next study is by Rohani and colleagues, and this study was published in Antimicrobial Agents and Chemotherapy. It's titled Individual Meropenem Epithelial Lining Fluid and Plasma PKPD Target Attainment. And just some background, hospital-acquired pneumonia is a common infection in the ICU and is associated with high rates of mortality. Prior studies have revealed that meropenem epithelial line fluid concentrations or penetration is highly variable in patients with pneumonia. And also we know that ELF to plasma concentrations can change as a function of time through a process known as system hysteresis. So this study really answered the question of whether our typical meropenem dosing strategies achieve PKPD targets in the lung in our patients that have pneumonia. So the study included patients who are actually enrolled for another study that was looking at specific biomarkers in patients with pneumonia. So those patients that had BAL and plasma samples that were available through typical or their routine clinical interventions, those samples were taken for inclusion in this specific study. So at this institution, meropenem is given as a loading dose, and meropenem is then typically given as a 3-hour extended or prolonged infusion. So that's just the typical dosing strategy at this specific institution. In terms of sample collection, as I mentioned, they included any residual bronchoalveolar lavage and plasma samples that were left over from routine clinical care. So they performed PKPD modeling. They performed a 2-compartment model structure. They looked at MAP, Bayes, and PK profiles for the first 24 hours of meropenem to attain the AUC in the ELF, the AUC in the plasma, to generate then the percent ELF penetration. Also looked at individual PKPD target attainment over the first 24 hours of therapy for each patient based on pseudomonal breakpoints. Then they looked at PKPD target attainment in 4 quadrants, and we look at those 4 quadrants. So they looked at one time the MIC and 4 times the MIC targets, and they divided their targets into an upper bound and a lower bound. So upper bound was 100% time above MIC, or 100% time 4 times above MIC, and the lower bound was acceptable if it was greater than 50% time above MIC, and suboptimal if it was less than 50% time above MIC. They also performed population PK/PD simulations and cumulative fraction response through Monte Carlo simulation. And they looked at patients with non-dialysis patients using creatinine clearance, and then they used effluent rate for dialysis patients. They also did the Monte Carlo simulation based on patients that received and did not receive loading doses. But they divided their cohort in terms of their findings in 2 groups: those patients that achieved 100% free time above the MIC and 100% free time 4 times above the MIC, based on MIC distributions for E. coli and Pseudomonas aeruginosa. So let's first look at the first 24-hour meropenem target attainment in the plasma and ELF of 65 patients. Okay, so the along the y-axis you have ELF target attainment and percent dosing, for the ELF, and along the x-axis you have percent interval in the plasma. So the first 4 quadrants represents 1 time above the MIC, and the second quadrants represent 4 times above the MIC. So what I want to draw your attention to is that almost all the patients attained greater than 50% free time 1 time above the MIC. So there was no problem attaining that goal. About 60% of patients attain greater than 50% free time 4 times above MIC, that higher target. But the concerning part is in patients that had greater than 95% free time 1 time above the MIC in the plasma, those 2 patients did not achieve adequate ELF concentration. So even though they had greater than 95% free time 1 time above the MIC in their plasma, they were not getting even 50% free time above MIC in their ELF. Similarly, there were 9 patients who did not achieve, who had greater than 95% free time 4 times above the MIC in the plasma, who did not achieve 50% free time above MIC in the ELF, right? So this again shows you getting adequate plasma concentration does not automatically translate to adequate ELF concentrations. Next, I wanted to shed some light on the cumulative fraction of response and draw your attention to the 2 red boxed areas of the table. So these 2 represent Pseudomonas at 1 time the MIC, and the bottom rows represent Pseudomonas at 4 times above the MIC. So if you see for the 2 dosing regimens in the yellow shaded areas, at 2 grams IBQ8 over 3 hours with a loading dose, and let's look at the creatinine clearance of 120 mils per minute. In your plasma, you get about 90% attainment, or cumulative fraction attainment, but this drops to about 80% in ELF. Without a loading dose in your plasma at a creatinine clearance of 120 mils per minute, your attainment is about 80%, and that drops to 60% without a loading dose. Now, if you go to Pseudomonas at 4 times the MIC, you see that in the plasma, with 2 grams IBQ8 dosing with a loading dose, target attainment 77% and drops to 60% in the ELF. And then at 4 times above the MIC, using the same dosing regimen without a loading dose, you have 60% attainment of CFR versus only 30% without a loading dose. So I think this data nicely represents that you really need that loading dose to push these exposures up. And because even without the loading dose, you're not getting great cumulative fraction of response. And so in order to boost that up a little bit more, you need those loading doses. So in summary, 40% of ICU patients in this cohort failed to achieve greater than 50% time above MIC in plasma and ELF, increasing their risk of treatment failure during the first 24 hours of therapy. Loading doses improved meropenem target attainment in the first 24 hours. And then in this particular study, what they found was that when they performed their analysis on baseline variables, they found that a creatinine clearance of greater than 150 mils per minute reduced the likelihood of PK/PD targets. However, a creatinine clearance of greater than 115 had a lower sensitivity when predicting suboptimal attainment. So you can't just use a creatinine clearance as a surrogate for these patients that have reduced PK/PD target, because that in itself had a low sensitivity for predicting suboptimal attainment. Some limitations of the study were lack of clinical outcomes, small sample size, and it should be noted that 1/3 of the patients had meropenem ELF concentrations below the limit of quantification. So I'm going to breeze through this study quickly in the interest of time, but I just want to mention to you that the Society of Infectious Diseases Pharmacists recently published a set of TDM guidelines for triazole TDM. And I think these are excellent set of guidelines for those institutions using or performing routine TDM in particularly in patients that have that are highly immunocompromised. I think there are some really great clinical polls and really good nuggets of information, things that are new to me as well. And so please, I'd encourage you to review these guidelines and look at what the recommendations are for specific azoles in terms of TDM. And just a final review, and this was a short paper, it wasn't a full study, but I just wanted to put this in there to really hopefully set the stage up for some of the new antibiotics that are coming out on the market. So tebipenem pivoxyl hydrobromide is a orally bioavailable carbapenem that is rapidly converted to tebipenem, the active moiety after oral administration. So tebipenem pivoxyl hydrobromide was found to be non-inferior to IV ertapenem in a non-inferiority study called the ADAPT-PO trial that looked at the two treatments for complicated urinary tract infection and acute pyelonephritis. And the issue and the reason for this particular study is that it's been long known, based on other studies, there's a discordance between clinical symptom resolution and recurrence of bacteria in complicated UTIs and pyelonephritis, particularly in patients with underlying genitourinary abnormalities. So this study was really looking at the impact of antibiotic pharmacokinetics in the urine on recurrent bacteria in patients with complicated urinary tract infections. So the study was looking at data from the ADAPT-PO trial, as I mentioned, that compared tebipenem pivoxyl hydrobromide with ertapenem. And the impetus of this particular study was based on the results of the ADAPT-PO study that showed that response at test of Q. So when comparing tebipenem versus ertapenem in terms of microbiological response, those were non-inferior between the two treatment arms. However, if you look at test of cure, that is about 19 days after, at the 19-day visit mark, as well as at sustained response at 25-day visit, you see decreased test of cure rates and sustained response rates in both treatment arms. So there was some question as to whether or not the urinary pharmacokinetics of tebipenem impacts the timing of recurrent bacteria and microbiological response. So there's a decreased responses at late follow-up. Does that have to do with the pharmacokinetics of the drug? So really quickly, I just want to quickly touch on this. So when they looked at the urinary pharmacokinetics, let's look at the graph on the left-hand side. you see that for ertapenem, we know it's highly protein bound. You see that you have higher concentrations of ertapenem that remain in the urine going out to 96 hours post-treatment. Compare that with tebipenem, where concentrations fall below the MIC of the pathogen, within 24 hours. And they also looked at the probability of target attainment of these concentrations like 1 week after administration of the drug. And as you can see from the graphs on the right side, that with ertapenem, you still maintain some concentrations of these drugs above MIC of the pathogen a week out from treatment. However, for tebipenem, this is not the case. So as these newer drugs are coming out, and often the first indication that they seek is for complicated urinary tract infections, understanding the pharmacokinetics of these drugs in the urinary tract is also extremely important for us in terms of understanding the efficacy of these drugs and how to utilize them best in clinical practice. So that brings me to the end of my presentation, and I'm happy to take any questions from the audience at this time. Thank you for your attention.
Thank you, ma'am. Your presentation is very nice. You addressed like most of the clinical practice papers, and we have some questions. And so, can I go ahead for questions, ma'am?
Go ahead, please.
Yeah. So in the one of your paper, you mentioned sometimes you have to consider MIC 4 times of MIC. So why we consider that? What is that actually? What is the reason for that? Why we consider 4 times of MIC in calculating the PD targets?
Yeah. So I think that's the hot button question, right? What to do. So as you all know, so the history behind the 4 times the MIC is based on some early in vitro work that was done by Bill Craig in his lab with Pseudomonas isolates, and basically what he found was that with beta-lactam specifically, you maximize bactericidal activity against Pseudomonas at 4 times above the MIC. So that's why the origin of the 4 times MIC is based on in vitro data. That's sort of been spilled over into clinical practice. And I will say in our own institution, we tend to use 4 times the MIC sort of as a fudge factor. Let me put it that way. So at our institution, we are still only performing total concentrations. So we don't have the capacity to perform unbound concentrations. So we often, at least in deep-seated infections, will target 4 times the MIC to account for a couple of things. As you saw from the study looking at meropenem, we are often not sampling from site of action. So we target 4 times the MIC to account for variability in penetration into the specific organ space. There's often variability in protein binding because we're still checking total concentrations. So that also favors slightly higher targets. And then third, and probably the most important, is I think we put a lot of stock into MICs. But remember, MICs are still very, very static values, right? I think exactly. And so we know that at best, there is at least 1 to 2-fold dilution variability there. So we also tend to target at least higher. And I think that's also another good point, is that even at our institution, I think ideally, we would like to target 4 times above the MIC upfront, empirically, when you know your patient's critically ill. And then once you know that you don't have a resistant organism to target, I think it's perfectly reasonable to back it off. Now, how to translate that into a study to look at that, I think is going to be a challenge. But those are some of the reasons why we target 4 times above the MIC. But at this point, I think there's very little data to support the higher target.
Okay, thank you. The next question in your presentation, you use that probable target attainment and cumulative fraction of response. So can you elaborate what are these terms like why using the PKPD things? Like, can you elaborate on this?
Sure. So the probability of target attainment is really looking at, and I think it was specific to the meropenem study, right?
Yeah.
Yes. So here they looked at probability of target attainment. So the goal that they were looking at is determining whether or not the drug concentration, meropenem concentration, was greater than 50% of each dosing interval. And at the 50% mark, were drug concentration one time above the MIC? So that was one target that they looked at, which is represented by the first quadrants. And the second quadrants is at the 50% mark, were drug concentrations 4 times above the MIC. And that's the second target that they looked at. I think this study nicely represents that we seem to be able to get the drug no problem to the plasma, but you know that a lot of times what we often do in the absence of TDM is to look at published data, to determine published ELF penetration rates for various antibiotics, right? So X% gets in. But I think this data nicely shows that that is highly variable because there is even interpatient variability on how much drug gets into the ELF. So really, in the absence of TDM, I think it's tough to say how much drug that we get there. I think the moral of the story is we should try to be, at least in our critically ill patients, as aggressive as we can be upfront, right? While the patient is critically ill and while we are awaiting further information about the organism that we're dealing with. The cumulative fraction of response, so this is data based on a Monte Carlo simulation. So they're looking to see the fraction of responses at the target of 100% free time above MIC for various. So how often are we hitting 100% free time above MIC for different creatinine clearance cutoffs? And in the Monte Carlo simulation, they put in several variables. So I think the renal function in the absence and in the presence of dialysis was put in, and also in the presence and absence of a loading dose was put in. So here we're looking at the percent of time that we're hitting that goal of 100% free time above MIC. And I think the moral of the story here is that you get adequate plasma and decent amounts of ELF penetration, but as these patients get augmented renal clearance, right? These are the problem patients are, I think, those young patients that have kidney functions or they have increased renal reserve. That's where you start to get into problems. So your target attainment, your CFR target attainment rates start to drop when your creatinine clearance also goes up. But then simply pushing your dose isn't sufficient. You need to first give it as an extended infusion, right? Because remember, this cohort, all their infusion were over 3 hours, and you need to give a loading dose. So you need to do those 2 interventions to get at least 100% free time above MIC. And even with that, as you can see, you're not doing a great job, but it's not awful. Hopefully you get enough time above MIC in the ELF for most pathogens.
Okay, thank you. The next question is, the most of the studies have lack of clinical outcomes. Like for a practicing clinician, like all these things are matter. Like what is your experience with your clinicians when you approach these kind of papers with your clinicians, like whether they change or accept your recommendations, or what is your experience? Yes.
Yeah, that's a great question, and I think this is that's been a little bit of our the dilemma with at least beta-lactam TDM, right? Is a lack of clinical evidence, and you know, whenever we have this conversation, I correlate things, you know, for better or for worse, with vancomycin. We never hold vancomycin to the same standards as we do beta-lactams, which we should be, right? Because I think we all know that vancomycin will fail terribly if we put it to the same rigorous nature of studies that we do today, in terms of proving that you know, TDM is actually meaningful, valuable, cost-effective, right? We want beta-lactam TDM studies to do all these things. So it is problematic. Now, I think that we are still learning about how to conduct these studies. And since the last, I would say, 4 to 5 years, we've had some high quality, and that's the good news. Prior to that, all our data with beta-lactam TDM have been retrospective, observational studies. But in the last few years, we've been having really well-conducted prospective trials that are really trying to address this question of what is the clinical outcome? What is that holy grail, right? It can't be mortality. That we know in ICU patients, it can't be that. They're way too heterogeneous. There is one subset of patients that are improving. The problem is that we know that those patients that benefit from TDM, it's like a bell-shaped curve. And there are patients on both ends of the bell-shaped curve that benefit most from TDM. But we're trying to find those two outliers, right? I think that's been the struggle with these studies, is what I described before as this dilution effect. The vast majority of patients don't need TDM, right? But when you conduct a study, you have to throw them in there. And so there's still some struggles. You know, again, you saw what happened in the dolphin study. This is the study that we looked at, the dolphin trial. It took them 36 hours to randomize patients. By then, some of that benefit is we've missed the boat. Even then, they were able to show that 40% still needed some kind of dose intervention. So I understand what you're saying. I mean, I think that there are new studies. So the BLING trial, which is a large TDM study, BLING 3 which is also a TDM guided study, is going to come out shortly. And I want to say they hope to include several thousand patients. So there are some studies that we anticipate coming out in the horizon, hopefully, that will shed some more light. But I think problems are identifying the right patients. I think we still haven't gotten that right. And you're right. I think finding that clinical I think it'll come all in line. Once we know those patients that benefit the most, we'll then understand then what the right clinical endpoints are to measure. But good question. I feel your pain, but I can tell you from our experience, once you start using at least beta-lactam TDM, that's where most of my experience is, you start seeing a lot of anomalies. You start to see old people that you expect to be accumulating drug, to be clearing drug like a 18-year-old patient, and vice versa. And you can't explain it, but if you didn't have the availability of TDM, you would never have recognized that.
That's a nice point. I think we don't have any questions further. And thank you, ma'am, for accepting our invitation.
Absolutely. And thank you so much. It was a pleasure presenting. And yes, I look forward to possibly attending some of the other presentations that you host. But thank you so much for your attention.
Thank you, ma'am. Thank you.